Welcome, everybody. Good morning. We have the last group of our sub-interns with us this month. Um, Welcome. I hope you all have had an opportunity to spend time at our different sites and you're learning as much as you can. It's a pleasure to have you around. They're going to be giving us their research talk. We're going to get started with our first presenter, Chiaguzim Anigbogu, who goes by Chi. Chi, tell us, I'm just going to continue with the tradition of Dr. Ellenbogen, who asks people to tell us where you grew up and a fun fact about yourself that we would not know about by reading your CV or personal statement for your sub-I.
Yeah. Thank you, Dr. Reverend Pay, for the introduction. Yeah, so I was born in Nigeria, but grew up in St. Paul, Minnesota. And a fun fact that you may not see on my CV is that during undergrad, I took a course in storytelling and then subsequently went on to be contracted as like a storyteller at parties and events. So during COVID, we were putting on shows for people all over the country. So a little stint of professional storytelling there for me.
Thank you. Maybe good everywhere, but hopefully not use that skill during consult reporting. Make it
Yes.
short and brief. All right, go ahead and tell us what you're going to talk about.
All right, let me pull up my screen. All right, so yeah, like I said, thank you all for the opportunity to rotate here. It's been a great experience so far, learning from the residents and having the time to spend time at the different hospitals and institutions. Today, I'm going to be presenting on the work that I spent the last couple of years working on in the Daniel Kramer lab, where we do a neuronal subpopulation classification using an advanced waveform analysis. So Parkinson's disease is the second most common age-related neurodegenerative disorder in the US. About 1.2 million people are diagnosed yearly. We know that the subthalamic nucleus is one of the structures that is often targeted for deep brain stimulation because of its role in the pathway of the manifestation of disease. There are many proposed models to explain and predict the role of the SCN in pathophysiology, from the rate model to the oscillatory and network-based models. However, despite these theoretical advances, we still lack definitive cellular or microcircuit level understanding of disease expression. So the goal of this project was to use an advanced waveform analysis to establish neuronal diversity within the SCN of patients with Parkinson's disease at rest, elucidating not only the diversity of cell types and the electrophysiological properties of these SCN neurons, but also to understand the spatial electrophysiological topography of the SCN. This matters because if we're able to understand the networks that contribute to understanding the networks that contribute to the disease helps us understand the pathophysiology. So in 2021, a group out in Boston had developed this new method of cell type differentiation that they called WaveMAP analysis. This tool allowed them to, in two monkeys within the prefrontal cortex, they're able to identify these 8 different neuronal populations seen here in Figure A. They compared their WaveMAP analysis to traditional classification methods and found that their methods were producing an accuracy of around 95% versus traditional models were having accuracies around 78%. This is interesting because not only were they able to identify these distinct neuronal populations, but they were then able to, using the same analysis, differentiate them based on what are considered broad spiking versus narrow spiking neurons, and then further elaborate on which of these neurons were interneurons. One of the interesting things about this project was that they were able to then sacrifice the monkeys and stain the specific locations in which the electrodes were placed. And we're able to see that even based on just in vivo analysis, that they were finding very promising correlations between what they saw in their analysis and what they saw in immunostaining. This provides another robust tool for in vivo neuronal analysis. So in our project, we have 16 patients undergoing SCN DBS implantation for Parkinson's disease. These patients were at rest. We used our surgical targets were determined based on preoperative MRI. And then the STN entry and exit were determined based on the microelectrode recordings. These were confirmed by a neurosurgeon, a neuroelectrophysiologist, and a neuroscientist. Then these recordings were then later processed and went through some spike analysis and sorting before we could then run our analysis. So before we can actually do our analysis, we have to filter our neuronal recordings through these exclusion criteria listed above here. This allows us to remove any duplicated recordings, noisy recordings, or recordings that we may consider to be non-physiological. Of the 1,038 units that we identified, 499 of them passed this exclusion criteria. We then averaged the waveforms seen here in figure B and normalized them from a y-axis of 1 to -1. This allows us to just visually see the characteristics of these waveforms. We then ran a series of calculations using the WaveMAP to reduce these high dimensional average waveforms and convert them into a lower dimensional space while preserving the structures and making it easier to visualize and identify uniqueness. After that, we ran a Louvain clustering on these normalized waveforms across a range of resolutions. This helps us to find what is a stable outcome for our analysis. And the outcome in these situations or the output, I should say, is neuronal subpopulations. So here in figure A, we see these are, we generated a 2D plot that visualizes these different identified waveforms within their Louvain clustering, and we placed them in a WaveMAP reduced space. So each of these different points represents a single unit or a single neuron. And then the colors represent which subpopulation that they're in. So here we see that we have 3 different subpopulations of neurons. We then take their clustering community or their Louvain clustering, and we pose it on the previous average waveforms. And here we're able to elucidate, or on visual inspection, we're able to now better see some of the distinctions between these different waveforms that we weren't able to appreciate just based on visual exploration. We then ran a confusion matrix for our 3 different neuronal subpopulation. This tells us how well our classification model did, and we see that for all 3 neuronal subpopulations, we're getting an accuracy of greater than 95%, which is always promising to see. Wanting to now see how well our WaveMAP analysis did, we looked at the differences between the 3 reported neuronal subpopulations when it comes to trough to peak time and then the action potential half-width. These are 2 features that are traditionally used in analyzing and classifying cells based on their extracellular waveforms. And we see that the 3 reported neuronal subpopulations are significantly different from one another based on these features, which is once again highlighting the accuracy of this WaveMAP analysis. We did this mainly for a sanity check because we know that the analysis is based on waveforms. So looking at these 2 traditional characteristics, we should expect them to be different. So then in wanting to understand what is the actual functional significance of these WaveMAP-derived neuronal subpopulations, we looked at firing rate. And we saw that the neuron subpopulation 1 was significantly different from neuron subpopulation 2 and 3, potentially highlighting a functional difference between these identified neuronal subpopulations, not readily seen by just initial waveform analysis. And wanting to continue this process of questioning our model, we then looked at the burst rate. And again, we see that the neuronal subpopulation 1 is significantly different from the neuronal subpopulation 2, highlighting a potential electrophysiological difference and potentially a functional difference not readily seen by initial waveform analysis. One of the questions of interest is whether we're able to appreciate a unique cell type spatial distribution within the SCN, potentially introducing cell-specific targeting in addition to anatomical targeting with MRI. And here we see that there is a the different neuronal subpopulations are distributed amongst the 3 different regions that we identified in the SCN, the ventral, medial, and the dorsal. This, again, we have to keep in mind that our patients are at rest, so this may not tell us much yet, but one of the future directions of this work is to look at these different distributions with while patients are undergoing some type of motor activity or motor paradigm during their deep brain stimulation implantation. And we would be interested to see, do these subpopulations change with initiation of action? So in summary, using the WaveMAP analysis, we identify 3 waveform defined neuronal subpopulations within the SCN with distinct waveform kinematics, firing rate, burst rate, and as well as anatomical topography. This waveform, it tells this is promising because now we may see waveform features can effectively serve as an in vivo marker for identification of distinct neuronal populations. Future direction is to expand this to Parkinson's disease patients who are not at rest, so including patients who are undergoing some type of movement paradigm, eye tracking, or tremor tracking. And in conclusion, the WaveMAP analysis may provide an additional robust tool for understanding not only the physiology of the SCN, but also the pathophysiology of Parkinson's disease. Might give us a clear understanding of how neuromodulation alters the microcircuits, as well as potentially may clinically offer a pathway to more precise DBS targeting. These are my references, and then acknowledgements.
Thank you, Chi. Let's give a few seconds to see if anybody from audience has a question. While we're waiting, I have a question for you. I mean, this may reflect my ignorance about the field, but so based on your talk, you are using electrophysiology to identify distinct cell subpopulations within kind of the bigger structure. Is there at any point a thought of what is the normal baseline? How would you not have to compare the whatever reading or functionality you're looking at these cellular subpopulations compared to a normal baseline because you mentioned that this is to understand the whatever is going on with these various cell types. You would want a kind of a normal control, and then how would you do that? What would be your normal population to compare and decide what is happening in these different cell groups?
Yeah, that's a great question, Dr. Rappenpayne. I think that's one of the ongoing discussions in the field, is that it's an ethical question of how to get these recordings where patients are undergoing a surgery, an invasive procedure. Often these patients already have some type of disease, Parkinson's disease, movement disorder, anything that we can treat with DBS. So there's an argument to be made that these are not, quote unquote, normal physiological brains that we're looking at. But we're not at the place where we can start to implant those people who are considered or who do not have disease. So I think that's one of the main limitations of this work, is that we're often looking at patients who already have some type of neurological process that alters the physiology of their brain. That being said, I think a lot of work has been done in animal models, and there is some correlate, like we're able to at least draw from what has been done in animal models to be able to better understand what we should expect to see in human models in terms of normal or physiological baseline. But yeah, it's an ongoing question of how do we get a good comparison when we can't have patients undergoing these invasive surgeries for no reason. I don't think any IRB would approve that.
Thank you. There are 2 other questions. One is Dr. Ramirez has his hand up, and then there is a question in the chat box. Dr. Ramirez,
Yeah.
would you like?
I found your talk extremely exciting and very interesting. And now that you mapped basically these activity and these neurons, have you looked, how they're activated during a tremor or, like during a movement,
Yeah, so
etc.? Are they differentially activated?
Yeah, so thank you for that question. That's one of the future directions, is that initially all these patients that we looked at, the 16, were at rest. But we do have the recordings already of patients who are undergoing. Our lab does a lot of eye tracking, as well as we'll do like inoperative finger tracking or movement that should, in theory, highlight the disease. So I think for me, going back to more research time would be able to look at those recordings and then be able to make the, start to highlight which neurons are, how the neuronal subpopulations are changing based on what the patient's doing. And then I see a question in the chat.
And we have a minute for you to answer that. It says, what were the Ilya Mirzai is asking, what were the particular neurons in your neuronal subpopulation?
Yeah, and that's one of the hard parts about this work is that we cannot specifically identify what neurons these are. I think one of the things that the paper highlighted was that in monkeys, you're able to get these recordings and then sacrifice them and do immunostaining to identify what, quote unquote, these neurons are. But in humans, we're not able to do that. So again, we're going based on what's already put out there in literature and to then say this is an interneuron versus an inhibitory neuron versus a slow spiking versus fast spiking neuron.
Okay, thank you very much, G. Stimulating talk. Next medical student up is, I believe, Abigail Cowher. She's visiting us from West Virginia University. Abby, tell us a little bit more about yourself and something we would not know about you by reading your CV or application.
Hi, everyone. So I was born and raised in Weirton, West Virginia. And my fun fact is that my party trick is that I can rap the entirety of the Eminem song Slim Shady, if you all are familiar. So I guess, is it okay if I get started with my presentation?
Yes.
We were all waiting for you to do it, but I guess maybe you should just do your presentation.
All right. So hello, everyone. Again, I'm going to be discussing today some of the research that I've conducted in West Virginia University's Gross Anatomy Laboratory. While I have conducted projects that apply to other procedures, the two that I'm going to be discussing today all pertain to anterior clinoidectomy. So the first study that I'm going to discuss details how optic canal size can be used to predict the presence of an accessory optic canal, which is a relevant neuroanatomical variant for anterior clinoidectomy. So, little neuroanatomy refresher. Typically, the optic canal, which is located in the lesser wing of the sphenoid bone, transmits both the optic nerve and ophthalmic artery between the orbit and the cranium. However, in some people, the ophthalmic artery is actually transmitted through the optic strut via a separate optic canal, most commonly referred to as the accessory optic canal, which has an estimated prevalence ranging from 0.22% to 16.6%, so pretty wide ranging. If you look at the figure labeled with the orange star, you'll see the normal anatomy with key labeled structures including the anterior clinoid process, optic canal, optic strut, superior orbital fissure, as well as the courses of the optic nerve, ophthalmic artery, and internal carotid artery, respectively. If you look at the figure labeled with the blue star, you'll once again see the normal anatomy, but this time the tissues are still present. And if you look at the figure labeled with the pink star, you'll see the variant anatomy. So the accessory optic canal is labeled with that blue arrow right there. So a little bit of clinical background. Anterior clinoidectomy is going to be used to expose the cavernous sinus and access the clinoid segment of the internal carotid artery for management of aneurysms and tumors within the paraclinoid region. Within this procedure, the optic strut is often detached along with the anterior clinoid process, both to facilitate enhanced access and to prevent any strut fragments from injuring the optic nerve or internal carotid artery during surgery. What makes the accessory optic canal so significant is that if you don't recognize it, you can blind or kill your patient due to intraoperative hemorrhage of the ophthalmic artery or internal carotid artery when you remove that optic strut. So the main problem that we sought to address with our research was that identifying the accessory optic canal on imaging studies is difficult. Not only can it be mislabeled, but even if you use a contrast medium to help improve your visualization, that bony septum that's intermediate to the optic canal and accessory optic canal still isn't going to be particularly well depicted in coronal CT. The main aim of our study was to measure accessory optic canals and optic canals and analyze these measurements to try and identify if there is any size and shape relationships between the two so that we can hopefully improve preoperative identification of the accessory optic canal variation. Our sample size was 111 dry cranial specimen. We wound up with 191 intact sides, roughly evenly divided between right and left. To collect our measurements, we fixed a pair of digital calipers to a known distance of 5 millimeters, held that flush to the canals, and then we took digital photographs. And then we analyzed the photographs with a software called ImageJ that allowed us to equate that known distance of 5 millimeters to a number of pixels. And that enabled us to obtain quantitative size and shape parameters, including area, perimeter, major axis, minor axis, circularity, aspect ratio, roundness, and solidity, all of which have been established for the objective measurement of cranial foraminal morphology. So this table here just compares all of the aforementioned parameters between normal optic canals and optic canals that had a coexisting accessory optic canal. And just to go ahead and draw your attention to the size of each group, 183 sides had normal optic canals, whereas 8 had a coexisting accessory optic canal, which gives us a prevalence of roughly 4.2%, and this does fall in the previously documented range I mentioned earlier. So in this table here, we used an independent samples t-test to discern significant differences among parameters for optic canals versus optic canals with concomitant accessory optic canals. And we found such statistically significant differences between area, perimeter, and minor axis. In this table here, we used a paired samples t-test to compare normal left and right-sided optic canals. And while we did find some statistically significant differences between sides, notably these normal optic canals were found to have comparable areas and perimeters, and I just highlighted that in the table for clarity. And this table here just showcases that we collected all the same data for the accessory optic canals that we observed. So the main finding from our study was that we found a statistically significant mean difference between the average cross-sectional area of optic canals that occurred alone versus ones that had a coexisting accessory optic canal. And we found that that statistically significant mean difference was roughly equivalent to the average accessory optic canal cross-sectional area. And we hypothesized that that small discrepancy that does exist may be due to the area that's occupied by the bony septum that separates the optic canal from the accessory optic canal. So conclusions from the study were basically that you can use this quantitative morphology to better discern the presence of an accessory optic canal on preoperative imaging to hopefully avoid serious complications when you're performing anterior clinoidectomy. And more specifically, asymmetry in the optic canal size between sides can help predict the presence of unilateral accessory optic canals especially well. So since So the second study I'm going to discuss incredibly briefly is a case report I wrote that also has implications for anterior clinoidectomy. The case was essentially that we found concomitant bilateral accessory optic canals in a right-sided coronacoclinoid foramen within an infantile sphenoid of a 12-month-old black male. And you can see the variant anatomy depicted to the right. Since I've already talked about the relevance of the accessory optic canal, I'm just going to take a minute to give some background on coronacoclinoid foramen. So these essentially form from bony projections from the anterior clinoid process, middle clinoid process, or both, and encompass the internal carotid artery posteriorly. They've been documented in the fetal and infantile population at a prevalence of roughly 1 in 5 individuals. So they're pretty common. General clinical applications include that they can stretch and compress the internal carotid artery, altering its morphology and potentially leading to ischemic sequelae like headaches. And then if these structures are incompletely ossified, the bony spurs can cause severe bleeding. Within the context of anterior clinoidectomy specifically, cortical clinoid foramen have been associated with increased risk of internal carotid artery damage, neurological complications, and fatality. So the significance of this case report is a couple different things. So one is that while these neuroanatomical variants have been independently documented in the PEDS population, the concomitant presence of the two has not been previously described. And then while that there are numerous applications of anterior clinoidectomy in the pediatric population, it's a pretty sparsely performed procedure. So because it's not going to be a regular part of really any pediatric neurosurgeon's practice, it's going to be especially important to generate awareness of potential operative pitfalls, including this relevant variant anatomy. Thank you very much. I will now take any questions.
Thank you, Abby. Let's see if anybody has any questions. Again, while we're all waiting, I noticed that you had 111 dry cranial specimens. How did you get your hands on 111 specimens?
Yeah, that's a question a lot of people ask. So the skulls from the majority of the skulls that we used for that first study I described were actually part of WVU's collection. So those were all in-house. But the specimen that we got our case report out of, that was actually obtained from the Cleveland Museum of Natural History in their collection.
Nice.
So, Dr. Roundtree, if I may comment on this.
Please.
So the study is entitled The Safety of Anterior Clinoidectomy, and I think you obviously focused on this ophthalmic artery, which I've rarely seen to be a problem. The main safety issue in reality relates to the size of the anterior clinoid, how far it goes back. In some cases, it can be very prominent, reaching almost all the way back to the posterior clinoid. And it can also be fused with the sphenoid bone. It's called the middle clinoid. Most of the time, we thin the bone out with a diamond drill, and we perform extradural clinoidectomy, but in patients, we may have to do extradural and intradural. In patients with aneurysms, it's often better to do an intradural clinoidectomy so that you have the vessels in view. In practice, we obviously use a diamond drill, but we can also use the Sonopet ultrasonic bone curette. There is a problem in using the Sonopet to decompress the optic canal. You can have actually blindness from that because the ultrasound vibrations can create some damage or the heating. The other thing, the only problems that I've seen are in removing the clinoid. Of course, you always have bleeding from the cavernous sinus, which is managed by injecting either powder gel foam or fibrin glue. You can actually damage the clinoid segment of the carotid artery. One of our erstwhile residents, Dr. Mike Meyer, did this for the first time. Then he showed me the way, and I did another time myself. But relatively easily managed in that location. Just put a piece of fascia and suture around it to hold it in place. So I think the other thing is the third cranial nerve runs very close by. It can also be damaged when you're removing the clinoid.
Thank you, Dr. Shaker. And thank you, Abby. Very nice presentation. We're gonna move on to the next student. Anne Lally is coming to us from Albert Einstein. Anne, tell us about yourself.
Yeah, hi, I'm Anne. I'm originally from Southern New Jersey, so Eagles territory more than like Yankees Mets territory. And a fun fact about me is I have a garden plot behind one of our like public hospitals in the Bronx, and we grow flowers, and yeah, it's fun.
Nice. Tell us about your research.
Yeah, so let me share screen. Okie dokie. So today I'm going to be giving a talk about one of our projects called Immunologic Activation, distinguishes grade 1 and grade 2 meningiomas. I have nothing to disclose, so the overall outline of this talk today, I'm going to be going into how we got to this question, and then following it up with the approach, findings, and future directions of my project. So to start off with, grade 2 meningiomas may represent a separate clinical entity. Oftentimes, we think about grade 2 meningiomas as an intermediate between more well-defined grade 1s and grade 3 meningiomas. Grade 1s are the most prevalent and reported to have about a prevalence of 80% in the literature, while grade 2s have a prevalence of 15% in the literature, which is still not an insignificant number. And the reason we at Einstein got into this question originally was a couple of years ago, someone doing a retrospective report on our meningiomas realized that 50% of our meningiomas were grade 2 or grade 3, and we started wondering more about grade 2 meningiomas. And so, well, although grade 2s are an intermediate between grade 1 and grade 3, there are documented differences and they have their own discrete clinical outcomes. But another issue with our grade 2s is that there haven't been many studies about the specific prognostic markers of them, while there have been more studies in grade 1s and grade 3s. So this lack of prognostic markers, combined with heterogeneous clinical behaviors, with some acting more like grade 1s and others acting more like grade 3s, have led to controversy in optimal management and trying to figure out which grade 2s we should radiate, which ones we shouldn't. And recent literature has begun to address this need. There have been new studies about different molecular classifications of meningiomas and other studies about which meningiomas may benefit more from radiation, but there have been very few advances specific to the WHO system. And so the goal of our project was to uncover transcriptomic features favoring grade 2 meningiomas. And to do this, we took 100 meningioma resection cases that we biobanked at Einstein Montefiore, and we did histologic assessment via WHO grading. We took batches of grade 1 and grade 2s, and we sent them for high throughput bulk RNA sequencing. We then followed that up with differential expression analysis to see what grade 2s were more expressing versus grade 1s. And we followed that up with gene set enrichment analysis to see what pathways were being represented in those grade 2s. And here is our table 1, basically, of our project. There were no statistically significant differences in demographics between our grade 1s and grade 2s. And so what we found is that expression of 9,127 genes was related to 11,000 pathways that distinguished our grade 2s. And so 3,500 about genes were upregulated in these grade 2s, while 5,615 were downregulated. And then when we did the gene set analysis to see what pathways were enriching, what we found is that the immunologic pathways were the most positively enriched, with 65 out of 100 of our top pathways being immunologic. And so we took this a step further and we identified the top 10 immunologic pathways that were enriched in our grade 2s compared to our grade 1s. And what we found, you can see for our top 2 pathways, it was related to intracellular signaling, but for all the pathways that I marked with an arrow, is also related to cytokine signaling, indicating cytokines were playing a role here. And then we took 5 specific genes that contributed most frequently to the top immunologic terms. So out of these pathways here, these genes contributed to 4 or more of them. And so we did a bit of literature review on these genes in the cancer literature overall, and then also in meningiomas. And what we found is that CCL5 was known for, in the tumor literature, for extracellular matrix remodeling and metabolic changes, but not well studied in meningiomas. CSF1 actually was studied in meningiomas, and in the tumor literature, it's known for immune escape. In meningiomas, in vitro inhibition of CSF1 has been shown to decrease tumor growth. Interferon gamma receptor 2 is a pro-tumor marker in the cancer literature. It's known for immune escape, but also not well studied in meningiomas. Similarly, IRF7, pro-tumor in the cancer literature, stimulates growth, but not well studied in meningiomas. And then finally, the trickiest one to interpret was CDKN1A. It's also known as P21. We typically think of it as an anti-tumor marker and know it in cell cycle arrest. But in meningiomas, it's been shown to have equivocal effects with some studies showing that higher levels of P21 are related to worse outcomes. Others show that presence of P21 is related to better prognosis. So it's a bit more ambiguous there and likely related to the levels of it, which kind of leads us into our future directions that where we want to go to this project is right now it's more of like a pilot study, but we want to increase our sample size and also send batches that include grade 3 meningiomas. We want to increase our power, and to better identify what makes grade 2 meningiomas grade 2, we should look at the differences between grade 2 and 3 as well as grade 1 and 2 and be able to combine those all together. Also, you want to assess the proteome, because what we did in this study is we took the tumor microenvironment and the tumors together in bulk RNA sequencing, and we want to know what proteins are actually there, what's actually being transcribed. In addition, we want to validate candidate pathways to see how these genes are impacting tumor growth. And finally, overall, what many groups and what we also want to study is that we want to understand how clinical outcomes are based on inflammatory profile, what makes grade 2s unique combined with what about subgroups of their behavior is leading to some tumors reacting better to treatment. And we also recently submitted an R01 for this work last year and came back with good feedback, and we're resubmitting it in November. So good things to come. And with that, I'd like to thank you all for listening to my presentation and thank my mentor, Dr. Vijay Agarwal, and my colleagues and our school-based group at Montefiore, and specifically Josh Reynolds for helping me with this type of research for this past year. It was very new to me. And with that, I am open to questions. Thank you.
Nice work. And while, again, we're waiting for maybe others to have questions, do you have a mechanism of flushing out maybe hematopoietic immunological cells infiltrating within tumors so that you can separate what you saw here in terms of transcriptional differences are purely tumor cells versus tumor cells mixed with other cells, maybe endogenous immunological cells?
Yeah, that's a great question. And for this project, no, that's one of the downfalls is that we use like bulk RNA sequencing. So tumors in the like cells in the microenvironment that aren't necessarily tumor were included, which I think is still important, still important cells, because the tumor microenvironment certainly leads to how tumor is going to behave in the future. Like single cell RNA sequencing would be better suited for that, and certainly something we're thinking about.
Maybe fact sorting the cells before you do the actual comparison, separating tumor cells from every other cell. Let's see if there are other questions. We have a few minutes for more questions. I don't see any hands up, and I don't see anything in the chat box. All right. Well, thank you very much, and beautiful talk.
Thank you.
Last but not least, we have Denis Routkevitch, who comes to us from Hopkins, where he's finishing up his MSTP program. Denis, tell us more about yourself.
All right, thank you so much. Yeah, so my fun fact is that I was a competitive fencer through college. So first of all, I want to thank the department for a fantastic month so far. It's been a really great learning experience. I'm going to talk to you today about my work with Dr. Theodore about the feedback control of blood flow after spinal cord injury. So to give you an overview, I'm going to detail a few problems with MAP management in acute spinal cord injury. And obviously, this institution is really familiar with MAP management of acute SCI. And so, but I identified sort of two main problems. And I'll go over sort of our approach to solving those problems and present you with a working solution, which is a real-time feedback controller. So the MAP management in spinal cord injury is really aimed to address the secondary phase of injury and specifically the ischemia that comes from it. So what we do is we elevate MAPs to 85, 90 millimeters mercury for the first week after injury, and we do so with norepinephrine or Levophed most commonly. There's two issues with this. So one thing is the reason we're doing this is to push blood into the site of injury and prevent ischemia, but we don't actually know that what we're doing is accomplishing that. Different patients, different injuries might have different map needs to maintain the same blood flow goals. And too many pressors can also be harmful for certain patients. And the second problem is that a human has to actually notice, so a nurse has to notice a drop in map or a change in map and go and adjust levofed dosing accordingly. And in places that are not the Harborview TICU, that can mean that you actually get like really significant time below map goals, which can result in harm to patients. So with those two problems in mind, I'm going to talk about our approach. So I worked with Dr. Theodore in the Hepius lab, and we were part of a large DARPA funded project to design an ultrasound implant that we can place directly after decompressive laminectomy. This implant can use blood flow, ultrasound to monitor blood flow in the acute phase, and then we can use that ultrasound measurement to direct map management. While we were sort of developing the device, I was working on how to use the ultrasound measurements. So I used a commercial transducer to measure blood flow in the spinal cord, and I have a few papers on analyzing the pre and post injury images. But today I'm going to talk to you about a more simple measurement, which is just the flow velocity through one of the sulcal arteries supplying the injury. And so all it is the mean flow velocity through the sulcal artery. And so if you see MFV through the rest of the slides, that just means blood flow. So now that we have that blood flow measurement, how are we going to use it to direct map management? I'm going to talk briefly about autoregulation, which should be a familiar concept to this group with Dr. Chesnut's work. But it's essentially the ability of an organ, such as the spinal cord, to maintain constant perfusion in the face of changing blood pressure. We're familiar with the Lassen curve, which is on the left, showing constant blood flow over a range of maps. But in the 90s, the field kind of came up with dynamic autoregulation, which measures changes in blood flow in response to changes in blood pressure. And I mention this because as an engineer looking at the graphs on the right, I kind of thought of it more like this, where we take blood pressure as an input to a single input, single output system and output blood flow. And the reason this is important is if we look at it this way, it immediately presents a solution where we can compare the blood flow to some sort of target. That gives us an error function, which we can put through something called a controller, which outputs an intervention, which goes through another system and eventually influences blood flow again. So this is an abstract system. How do we break it down? We have MFV, that's our blood flow output. We have blood pressure, and our intervention is just the infusion rate of norepinephrine. And with that in mind, there's just a few edits to the system you have to make it accurate. So this addresses our two problems. So the first thing is we've transformed map management into blood flow management, so no more guesswork. And in this case, if we can actually implement the system, we have a computer sense perturbations in blood flow and respond instantaneously to them, eliminating that human component. So how do we actually fill this out? I'll just give you a very brief overview. We just have to collect a whole bunch of data, do a whole bunch of mathematical analyses, and we end up with a mathematical model that represents each one of these little boxes. And we represent these little boxes, and once we compile all the little boxes, we can get an actual in silico model of our physiology, in this case, a rat. And this is all we need to design a controller. So it's time to do that. We use a technique called H-infinity control, which is all it does is you can design an optimal controller based on certain parameters. And our parameters are very simple. Our goal was to minimize deviation in blood flow, as well as changes in map. But we also wanted to avoid overly aggressively infusing norepinephrine because that can also cause harm to the patient. And once we do that, we just, our algorithm spits out a controller, and our closed loop system is complete in the computer. In simulation, we can test this in a few clinical scenarios. So for example, if our patient's not doing so well as Asia A, we can decide to increase blood flow. So we just turn up the blood flow knob on our controller. And then the system will automatically, in the top graph, titrate norepinephrine in order to reach blood flow target within about 2 minutes. In the case of hemodynamic instability, so a sudden drop in MAP as shown as the middle plot, once again, the controller will respond with norepinephrine as shown in the top plot, and blood flow will return to baseline within 2 minutes. And it's also stable to more gradual decreases in MAP for any other physiologic reason. So that's all well and good that it works in simulations. We can actually implement this in real life. So on the right, we can take our MFV blood flow measurement that we already described, just put it into our computer, which does its calculations through the controller, and every second outputs a new infusion rate of norepinephrine to a syringe pump, which then pumps norepinephrine into our subject. And our closed loop system is complete. And we can see that it works exactly like the simulations do, where we have essentially, we can turn the blood flow knob up and increase blood flow. We are stable to rapid decreases in MAP, and we are also stable to more slow decreases in MAP. So it works exactly like the simulations. And it's statistically significant across multiple rats. So I've shown you a working solution, which is the feedback controller, but we did this in rats, which are not humans. So we wanted to do this again in pigs, which are a little bit closer. So we repeated this entire process with just a few experimental and design tweaks. and showed that it works in pigs as well. So our blood flow knob works. We can increase the blood flow by 20% in our patient. And we're also stable to rapid decreases in MAP in the pigs as well. And once again, it's statistically significant. I'm going to show you briefly how this works across a long period of time. So in this experiment, we just put our pig on the blood flow controller and we just turn the knob up and down every 30 minutes or so. And you can see in the bottom trace, the red line is our actual blood flow and the dotted black line is our desired blood flow. And we see that it tracks very, very nicely to our blood flow control. Here's how it looks in real time. So after a drop in blood pressure and blood flow, our controller automatically responds to that. And we're back at baseline very, very quickly. This is sped up, of course, but within a minute. So what has this given us? We've addressed those two major problems that I told you about acute spinal cord injury care. So first, MAP management is now blood flow management. So rather than guessing at what we're doing to the cord, we know what we're actually doing to the cord. And second, we're immediately responsive to hemodynamic instability. So we've eliminated that human component that is maybe less of a problem in the Harvard VTQ, but much more of a problem everywhere else. And many other diseases use MAP management. Again, this institution is very familiar with Dr. Chestnut's seminal work in traumatic brain injury, but there's other diseases that use it as well. The kind of nice thing about this is a design process, and all it takes is a computer and a little bit of math, and you can plug and play all the different other parts. So you can plug and play the infusion pump, the physiology. So this is really adaptable to different diseases, and as a result, it also has simple translation. Like we can do this with what's available in the clinic already. Some limitations. In the spinal cord, blood flow remains really difficult to measure. MFE is not maybe the best spinal cord blood flow modality, and Dr. Hofstetter has really some great work on ultrasound for blood flow analysis after spinal cord injury as well. But we still really need a clinical spinal cord blood flow modality that we can do long-term monitoring with. And so we've done some work with near-infrared spectroscopy in our pigs that shows that we can do this with that as well. Second, different patients might have different physiological needs for different controllers. So we've actually also shown that we can develop a personalized controller for individual subjects as well. And finally, FDA approval for closed loop systems remains kind of a difficult hurdle, but within functional neurosurgery, there's been some precedents that have emerged. So we can look to those as inspiration once we seek to translate. So I want to thank Dr. Theodore and the rest of the Heppius lab, who have been an incredible team supporting through all of this. This work wouldn't have been possible without them. Once again, I want to thank the UW department. It's been really an honor working with you guys, and I'm really happy to take any questions.
Thank you, Dennis. Beautiful work. Let's see in the audience. I know you're going to spend some time with Dr. Hofstetter later today. He has his hands up. Yes, Dr. Hofstetter.
Hey, Dennis, thanks so much for presenting your work. Super excited to kind of learn more about it. One question I have for you, you picked, the blood flow in the sulcal artery to have basically as your primary outcome variable that you optimize. We all know that in stroke and injury, there's phenomena like such as, steel phenomena, like areas where you increase the blood flow and other areas decrease. Do you know how in relation, how the blood flow of the sulcal artery relates to the rest of the spinal cord?
Yeah, well, so the blood flow through the sulcal artery, if you look at like an axial cross section, supplies, I think, 2/3 of the cord. So I think it relates pretty well, like as you look at it axially. But I think like from a craniocaudal perspective, it maybe doesn't. And so one of the things I'd wanted to do with my work was to look at sort of the spatial distribution and see how that relates to this as well. But I haven't gotten to that yet. And obviously, what you've done with your paper has been really cool in that respect. So I would be really interested to see how we can sort of adapt that kind of, like, if we can take that spatial distribution of blood flow across the injury and adapt that into maybe a better outcome variable than just flow through one sulcal artery.
Yeah.
Dr. Chestnut has his hand up as well.
Yeah, hi. I have two questions. One, you made a very important point that pressure is not blood flow, but then you used a blood pressure agent as your sole manipulative device. And I was going to wonder if you had looked at other things like inotropes or preload.
Oh, yeah, sorry, I didn't mean to cut you off.
No, well, there's two questions. The second one is, depending on the preservation of autoregulation, you might see a different relationship between the turning of your knob, your input-output relationship, the turning of your knob and the blood pressure response. And I was wondering if you've seen any of that.
Yeah, absolutely. So thank you so much for both those questions. So in regards to the first one, yeah, we have used inotropes as well. In fact, some of that adjustment that I made to sort of the mathematical framework comes from a few of our other studies in pigs using inotropes and showing their differential effects on blood flow. So this first pass at the mathematical model really kind of one single intervention is the easiest place to start with. But obviously, actually, somebody in our group currently is looking at combinations of vasopressors and inotropes in order to create sort of like an optimal blood flow changing paradigm. And so eventually, like this, we'd hope to have this feedback control system with multiple variables that we can modulate at the same time. And then as far as the second question, remind me of that one real quick.
It was about the IO relationship reflecting various degrees of autoreg preservation.
Yeah, absolutely. And so that I think we've seen a little bit of that where like depending on the type of injury, you might have changes in how the system responds. And I think the answer to that lies into sort of one of the last points I made of each individual patient probably has an optimal controller. And there's patients maybe that have intact autoregulation that don't need this kind of control because they don't actually maybe need MAP management. They're doing just fine without it because autoregulation is intact. But then if they're not, then this is when it really becomes a factor. And so eventually when this is translated, I would hope to have some sort of sensor for how much autoregulation is actually present, and then you can adjust accordingly how your controller works.